Good evening, everybody. Thank you very much for joining us this evening. You're watching the webinar session, which is the BFAST Hunter Update for Hyperacute Stroke Treatment with Dr. Carlos Garcia Esperon. My name is Sandy Vincent. I'm from the PHN Education team, and I'll be facilitating tonight's session. I'd like to start by acknowledging the traditional custodians of the land that we live and work on. Today I'm in Darkinjung land and pay respect to their continuing culture and contribution to the life of this vast region. Before we begin, just a few things to let you know. This session is being recorded. The recording and the PDF slides will become available on the PHN website in our education library within the next couple of days. As attendees, your camera is automatically disabled and your microphone will be automatically muted. If you do have questions during the presentation, please send those through via the question box. Sally Ormond, Clinical Nurse Consultant from Hunter Stroke Services, is here on the panel tonight, and Sally will facilitate those questions at the end of the session. Thank you very much, Sally. An evaluation, including the learning outcomes, will come to you directly after the session, and we'd be very grateful if you would complete that. It's now my great pleasure to introduce our speaker for tonight's session. Dr. Carlos Garcia Esperon is a stroke neurologist and researcher at John Hunter Hospital. Dr. Garcia Esperon undertook clinical training in Spain, Switzerland, and Australia. He completed a dissertation in ischemic stroke at the University of Bern and is currently undertaking a PhD program at the University of Newcastle, focusing on the implementation of multimodal CT in acute stroke treatment. He has presented extensively in regional and rural centres in New South Wales on the role of telethrombolysis in stroke management, educating healthcare professionals in its role in acute stroke treatment. Despite being in his early stages of his research career, Dr. Garcia Esperon is heavily involved in acute stroke clinical trials and is widely published. Thank you very much for joining us, Carlos, and I'll hand over to you now.
Thank you. Thanks, Sandy. I assume that you can all see my screen. Yep, perfect. Yep, this is working. Excellent. Hi, everyone. I'm Carlos, and it is very comprehensive introduction. I discouraged her to do these things. I'm not a big fan, but she had to do it. It's not her fault. I appreciate it. I definitely prefer to keep it very simple. I'm Carlos. I'm one of the stroke neurologists, and today we are going to talk about a few things that I think that they are very relevant to know what's happening. So these are the learning objectives, and I will start talking about the thing that is my passion, the hyperacute stroke. Following to that, I will talk a tiny bit about New South Wales telestroke and the pre-hospital phase, and I will finish with what's the most complex kind of a stroke, how to manage the TIA and the minor stroke management. So quite a lot of things to go through. So I hope that this is fairly entertaining and you would be able to enjoy it. Something that hasn't been mentioned, there is a very thick Spanish accent. That's actually where I'm from. I'm from a beautiful place in the world called Galicia. You definitely should check it. And you can feel a bit like that during my presentation. So definitely just relax. I hope that you are having a good evening and we can go through a few things. We know this, we know that time is running, and you heard that 1,000 times in 1,000 of different campaigns. Sorry. And actually, one of the neurologists in US, one of our colleagues, actually was able even to quantify the neuron lost for stroke per hour, per minute, and per second. And you can see the figures there, and you can see the impact on recovery on those patients after a stroke. So definitely we know that every minute matters. And I would like to run through all the hyperacute phase through a patient that might be a classic patient that we would see around. So Mr. X, he's a 77-year-old male. He had probably an elevated alcohol consumption, 4 or 5 beers per day, atrial fibrillation on dabigatran for the last 5 years, and that was stopped. We have not much information why this happened. So yesterday he was at 5 p.m. He was at the pub. He's developed some headache, were finding difficulties, and right side weakness. So someone called the ambulance, and the patient arrived actually around an hour and 15 minutes after. Patients like him, we are going to see him all the time. Unfortunately, 1 in 6 Australians will suffer a stroke. It's one of the leading causes of disability in Australia, and there's 50,000 new strokes per year in Australia, around 15,000 in New South Wales. So most of the strokes, we will talk about that, are ischemic clot strokes. So definitely we need the treatment strategies is what we call the early reperfusion, trying to dissolve or remove the clot. So the patient arrives to ED, arrives there, you can see on the top, 6:35. So actually symptom onset was around an hour and a half ago. Initial steps, ECG, blood tests are normal. And actually the neurologist team assess this patient and see that's the assessment by the neurologist, and can see that there's a gaze preference towards the left, which is something that we see in these big strokes. There is a right homonymous hemianopia, so the patient is unable to see properly through the right visual fields in both eyes, a facial palsy, a hemiparesis, and there's a mixed aphasia, struggling to understand and to find his words. And the NIHSS, which is the stroke scale, is 20, which is a scale that goes from 0 asymptomatic to 42. 20 is pretty high. So the first bit is, what kind of imaging should we do for this patient? So this is a patient that is on the window of treatments, and we will talk about that. So we will go a few through. I give you here a few options. You can think about that. There's no questions around, but you can think about that. You want to do just a non-contrast CT, a CT angiogram, a CT perfusion, perhaps an MRI that would be desirable, or go straight to a cerebral angiogram. A combination might be. Definitely the first step that you need to do is a non-contrast CT, and something that is applicable for all the strokes. We need to rule out that the patient is not having a hemorrhage. And this is something that, believe me, can be extremely difficult even from the clinical history or from the symptoms. Most of the patients that are taking anticoagulants, they will have an ischemic stroke, not a hemorrhagic stroke. So for instance, this is the CT scanner on our patient, and you can see that there is nothing acute, there is no hemorrhage, there is no white areas. And there's probably a nodal stroke here on the right. But interestingly, when we move at the CT arrow, the CT angiogram, he has the arrow sign, and you can see here that there's an MCA, left MCA occlusion, an M1 occlusion. And pretty important, the carotids were open. This is not a great picture, but important to keep in mind always to image or have a fair image about on the extracranial vessels. So this patient already, we know that had a normal non-contrast CT, and the CT angiogram has an MCA occlusion. But in that case was pretty straightforward. But the reality is that the patients, when you take a look at the non-contrast CT with a hyperacute stroke, it's not everything black and white. Like the patient here, these are 3 different patients. The patient in the left definitely has a very normal CT. The patient on the right has an established stroke on the right basal ganglia. But what about the patient in between? This is the reality of what we've seen most of the times. Here, where the eyes circle these areas, you might agree with me that probably the cortex doesn't look as well delimited compared to the contralateral sulci. So in something here, you cannot see these brain structures as well. That's the reality. Is that established stroke? Is there still tissue there to save? And that's where the CT perfusion helps us to quantify the tissue damage and how much tissue we can save. So the CT perfusion actually is that rather than taking a single snapshot, that would be a CT angiogram, we use the contrast injection and we create like a movie, like usually around 60, 70 seconds. And we can calculate how the blood flow is and how long takes the blood and the contrast to go through. And using different parameters that they have been developed mostly by the group in Newcastle, Parsons, Levi, and Spratt, we can define between 2 different parts of tissue, the tissue that is already very likely damaged irreversibly, what we call the core, and the penumbra, the tissue that, in case of dissolving that clot, can be still salvageable. These are the pictures that the CT perfusion produces, which are fairly complex to understand, but all these, the softwares are able to simplify in these what we call core penumbra maps or green-red stop-and-go maps. And here, in the same patient, you can see that patient with an MCA occlusion, now we can see clearly how there is a considerable amount of tissue to save, the green areas, and very little tissue already damaged, the red areas. This is a very favorable pattern for this patient to receive reperfusion therapies and be treated. And actually that goes to the concept of what's the penumbra. When a patient has a blockage, that tissue slowly dies, but how quick that brain is dying, it depends and is highly variable among patients, as everything depends from what we call the collateral circulation. And the collateral circulation comes from extracranial vessels or leptomeningeal ones mostly, or otherwise anterior cerebral artery and posterior cerebral artery towards the middle cerebral artery, meaning the vessels and the vascularization in the brain is very different among patients, which means that some patients after 2 hours, there's very little to gain. Other patients, we can still find tissue to save up to 24 hours. We will talk about that. But a non-contrast CT is not good enough to be able to differentiate between these two patients. How I like to see it is like that. The world changed, and taking a look at the non-contrast CT in an acute stroke. Again, we are talking here about a hyperacute setting in ED. But be thinking about this, the first Apple computer in the left, and actually that no one would be using that laptop, and you would be using probably the one on the right. So just summarizing the benefit of what the perfusion imaging is that using the perfusion imaging to guide our treatments, we can achieve the following. Those patients that have what we call target mismatch, which means lots of tissue to save and not a huge amount of damaged tissue, has a 23 times greater chance of having an excellent outcome and 77% reduction in mortality. Those patients with already what we call a large core volume, a tissue, an amount of tissue that is already reversible, the red areas, has a 48% increase in mortality and 9 times greater risk of having a symptomatic intracerebral hemorrhage. What's the fear one? Those patients with very small perfusion lesions, we know that the majority, they wouldn't benefit for thrombolysis. And those patients that don't have tissue to save has 16 times greater chance of having a poor clinical outcome, which means that those decisions that was considered in the past a bit random, treating patients based on a non-contrast CT, now we have solid data that has been after thousands of patients about how we treat and how safe it is to treat based on CT perfusion. So back to that patient, and now we know about the patient that has a left MCA stroke, M1 occlusion. This is a very disabling stroke. And the patient has a very favorable perfusion maps, and there's no hemorrhage there. So it has a clotted stroke and a lot of tissue to save. What treatment would you decide to start? Definitely, I give you there a few options for you to think about it. But definitely, I will run the right one would be in this case, definitely the F. We will talk about that, the combination of thrombolysis with alteplase and clot retrieval. Thrombolysis is the first step of treatment for a stroke. It's something that is delivered at the Comprehensive Stroke Center. I'm based in Newcastle at the John Hunter, but also in the rural sites of the telestroke network, as they are Moree, Tamworth, Armidale, and Taree. The problem with thrombolysis is that it's extremely beneficial for those small clots, but in a patient like the one that you've seen, will not benefit, as it is not ideal to dissolve the big clots. That doesn't mean that doesn't help. Around 10%, 1 in 10 would be able to dissolve it. That means we should start with thrombolysis, but we shouldn't stop there. And we should also combine thrombolysis with another treatment. Some limitations for thrombolysis is that if the patient is on an anticoagulant and is compliant on warfarin and the INR is greater than 1.7, had a recent surgery, a classic scenario of having a stroke, might not be suitable thrombolysis for the patient. And as mentioned, the larger the clot, less the likelihood of recanalization. Back to the patient, we started thrombolysis. There was no clinical improvement, so we need to move towards another treatment. We need to work on parallel, and when a patient comes with a stroke, we don't wait to see if there's a recovery of thrombolysis. That would definitely, if we remember the first slides about time is brain, that would be already causing some more brain damage. And we work in parallel, and already as we are dripping the thrombolysis, the team is being activated towards doing thrombectomy or endovascular clot retrieval. They are both synonymous, as you know. And this is for every patient with an ischemic stroke caused by a large artery occlusion and that has tissue to save. And I will show you we have evidence offered this treatment in the big strokes, in some of them up to 24 hours. That doesn't mean that every stroke will benefit of this, but a small proportion of them might benefit up to 24 hours. Most of the patients have a femoral access, as you can see here in the picture in the left, but we can do, as cardiologists, some patients we do radial access, not so often. And here you can see how these devices, these clot retrievals, go through the clot and just trap the clot. And you can see a great example that is in internet with a very, very, very large clot there on the right. Why thrombectomy? Is that beneficial? It's very powerful thrombectomy. This is a picture and the results of the outcome of the first thrombectomy trials. Thrombectomy for stroke is approved since 2015 after 5 randomized clinical trials in the world show the benefit of thrombectomy. So here you can see the outcome compared thrombectomy versus those patients not receiving thrombectomy in 3 months outcome after, again, a very disabling strokes. These are not small strokes. These are strokes that they are caused by a large blockage in one of the most important arteries in the brain. And in those initial trials, the patients with thrombectomy, almost 1 in 2, was able to be independent 3 months after a stroke, compared to 26% in the medical treatment. And actually, you can see those numbers in moderate dependent and how also thrombectomy decreased bedbound and death compared to medical treatment. The number need to treat to have a patient to a normal life before a stroke is actually 1 in 3. That's extremely powerful therapy when you think how many aspirins do we need to start to prevent a stroke. For example, we need hundreds of patients we need to treat to be able to prevent an event. And here, just treating 3 patients, 1 of them is going to come back to normal life, back at work, no disability. And this slide looks a bit funny, but CT perfusion allow us to identify those patients that might be able to benefit from thrombectomy up to 24 hours. And this information comes from 2 large randomized clinical trials published in New England in 2018, in which they include patients like the picture in the left with still tissue to save and little damage, but not excluding those that they had already a clear established stroke. And they've just tested the hypothesis. Did these patients still with some tissue to save benefit of thrombectomy after 6 hours? That is the classic window. Do they benefit after 24 hours? And indeed, they found there that still the number need to treat to have a patient independent after a stroke, it actually holds there with a number need to treat 3 to 4 up to 24 hours. Again, that doesn't mean, and I would like to clarify this, that every patient with a stroke will benefit for treatment after 24 hours, up to 24 hours. No. That means that following what I mentioned before about collateral circulation and those small vessels keeping the tissue alive, some patients, they have such a great developed network of vessels providing supply to that part of the brain that is able to keep that part of the brain alive up to 24 hours. That's a minority of the patients, but it's still worth to screen those patients presenting with large strokes. That's especially very important for those patients that they wake up with a stroke. That is actually 1/4 of the patients that classically they were not considered for treatment. Back to our patient. These are actually true imaging. This is a patient that has the patient has an MCA occlusion. Remember the CT angiogram that I showed you. This is the initial the picture from the cerebral angiography. So this is a coronal projection, and you can see here this is the internal carotid artery, this is the MCA proximal, this is the ACA, here is a blockage, and after a pass of clot retrieval, you can see after the stent retriever, you can see the clot there on the right, you can see all these beautiful branches coming on the left middle cerebral artery. And this is the follow-up scans. You can see this patient had a CT that tells you that probably something is happening here, but the MRI is much more clear, and you can see mild damage in the lenticular area. But if you keep in mind how large was the tissue to save, you can imagine how much of the brain was saved and how small and little is the damage. Of course, I'm showing you a case that does great and phenomenal, and unfortunately, many other patients, they don't through, but definitely this is not experimental therapy. This is something that we are offering day to day to patients in Hunter, New England and beyond. Couple of questions. Tenecteplase, perhaps some of you heard about, shall we use tenecteplase to thrombolyze patients with a stroke? Reality is not yet. We know that tenecteplase is a very promising molecule. We know that our colleagues from cardiology use it. We know that is here in the top a few things, more fibrin specific than alteplase, the molecule and the drug that we use. Many other things, extremely appealing to use as a single dose, as a bolus. And we have beautiful data that is phase 2b data coming from our group, published by Mark Parsons and Chris Levi in Newcastle, showing how the patients receiving actually tenecteplase's dose of 0.25, not 0.5, were more likely to have an improved clinically and reperfuse and dissolve the clot more likely compared to alteplase. But this is not what we call phase 3 randomized clinical data, which means this data is promising, but that points that we need more studies, as currently are happening. We are running a very large randomized clinical trial called TASTE trial that we are hopeful to be able to finish at some point, perhaps next year, and will bring solid data. Some of you might be aware, actually, there's a world shortage of tenecteplase. Another question that you might have is, okay, Carlos, you told us that thrombolizing a patient with a big stroke, with a big clot sitting there, little the benefit. Can I just skip the thrombolysis and go straight to clot retrieval? And actually, many trials were trying to answer that question, and I show you here the data of pool analysis. And in this data, this is a busy slide, so I will guide you through it. They compare those patients receiving combined therapy, which means thrombolysis plus thrombectomy, versus those patients that they decided to skip thrombectomy. They could have received, they skip thrombolysis. They could have received thrombolysis, but they went straight to the cath lab and had thrombectomy. The primary outcome was 90 days. We always doing a stroke. 3 months after a stroke is always our measure to see how the patients are doing. And the primary outcome was what's called the modified ranking scale 0 to 2. That's the scale that we use to measure outcome. 0 to 2 means the patient is back to a normal life. And you can see that those patients, the difference between those that they went to thrombectomy versus those that received both treatments was pretty similar. This is non-significant, which means skipping thrombolysis wasn't beneficial for the patients. And when you look actually to other outcomes, 0-1 or 0-3, patients including minor disability, the results are very similar. And most interestingly, there was not increased hemorrhagic risk in the patients thrombolizing. So definitely there is no evidence to skip TPA before thrombectomy. And even more important, if the patient is not at the John Hunter Hospital, but the patient is in a rural site and needs to be transferred, a 10% chances of recanalization on the way is definitely good, and we need to grab to that 10% because you can save a lot of time, as it's quite challenging to arrange a transfer from rural sites, and we do that routinely. Very quick mention, there is I mentioned before, there is besides the John Hunter area that I will flag to you, there is a network that is currently providing services to New South Wales, and it's called the New South Wales Telestroke Network. And this is a network that connects, you can see there in the picture, with the patient direct and with the rural sites, and supports the rural physicians and in the decision of should we thrombolize this patient, yes, no, should we transfer this patient, yes, no, to the comprehensive stroke center. Few pictures here, many familiar faces, but very interesting. I think there's a few good things in the network, especially keeping our great colleagues from rural, and you can see some of them here. And basically, if a patient has a stroke and is identified by New South Wales Ambulance, would go to the closest primary stroke center connected to the telestroke network, for example, Tamworth or Taree, Armidale, Moree, all these sites, they would do it. They would call the neurologist on call for telestroke. For example, I'm tomorrow on call for New South Wales telestroke. I'll be there taking that call. And we will assess the imaging together. We will decide whether starting thrombolysis in the rural site and which patient needs to be transferred, if any, to the comprehensive stroke center for clot retrieval. key has been probably around education and training for staff. And actually, one of the bits of research that we are doing on top of that, our colleagues from the University of Newcastle, HMRI, Rowan Walker and his team has been actually developing a package of training using virtual reality, which is something that we are is very, very appealing and definitely pretty interesting. This is a slide taken actually from a few days ago, and I definitely would like to thank the New South Wales Telestroke for all these ones. You can see that currently New South Wales Telestroke is providing services to all these circles here. You can see the names of the sites, and the circle is how many patients have been. The larger the circle, the larger the number of patients treated or assessed in that hospital. Mind you, that's not all the sites started at the same time, so you can see here Port and Coffs were the first sites that we started with New South Wales Telestroke, so important to keep in mind. So 23 live sites at the moment and 2,300 Telestroke cases. And important to keep in mind, all this work has been leveraged by local work performed here in Hunter, New England by actually Chris Levi started the Telestroke services, providing services to Tarry back in April 2013, and sites like Tamworth, Armidale, Moree, and then Port and Coffs jump, and they have been having access to thrombolysis and thrombectomy since years ago, supporting also the local neurologists as my colleagues in Tamworth. What happens in our immediate John Hunter catchment? Probably some of you are from this area. We have set up a New South Wales bypass, from the ambulance. Actually, it's a 90-minute radius. I think that's my Google, so apologies about that, of 90 minutes driving distance from the John Hunter Hospital. And actually, if a patient presents with a stroke symptoms in that area, New South Wales ambulance will go through a few questionnaires that I will show you, and we'll call the stroke neurologist or the stroke fellow advanced trainee on call at the John Hunter Hospital, and we'll decide whether the patient is deemed to be transferred straight to the John Hunter or not. For that, they use something that is called the Hunter 8. This is a pre-hospital stroke scale. There are many used in the world. It's based on 8 items of the neurological assessment, and is good to identify those patients presenting with a large stroke. With data that we collected for many years, we know that those patients scoring 8 or more points are pretty likely to have a large vessel occlusion and likely to benefit from a direct bypass towards the John Hunter Hospital, as we are the only site in Hunter, New England having clot retrieval. This is the bypass. My apologies. This is the workflow that my colleagues from New South Wales Ambulance use. And you can see that it's a combination of the premorbid function, what's called the modified ranking scale, and the stroke severity. Unfortunately, we cannot help with all these therapies patients that they already have a poor premorbid function. So if a patient already is highly dependent, nursing home, there's no evidence that any of these therapies is going to benefit. And definitely those patients would require to go to the closest stroke unit, might be ourselves at the John Hunter or a few others. If the patient has a mild disability or is independent, then they use different thresholds for each window, and they would use different scores, and that would guide them through the algorithm towards calling the stroke neurologist. I think that's all from my hyperacute bit. I'm not sure if there's any questions. We'll pause here for a minute if there's any questions in the audience, Sally.
Hi, Carlos. No questions at the moment.
All right then. Still sounding English, not too Spanish. I'll keep going then.
Okay.
I'll jump now to what's probably most. I just wanted to show you a bit what we do in the hyperacute phase, as I think that is important, as many of these patients, they still present the clinic with symptoms. A couple of hours, you're the first port for the patient, you're the first person to go for many of them. But the challenges come on these ones. Honestly, the difficulty is how you manage the TIA and the minor stroke. Important. Is a TIA, is a minor stroke? Look, most of the TIA's reality is that they are going to be minor strokes. They are the spectrum of the same disease. All depends what imaging are you doing. If you do a non-contrast CT, probably you're not going to be able to see the small ischemic area in the patients. If you do an MRI, you would be able to see it. That doesn't mean that I'm encouraging you to do an MRI. That's something that we can do in the clinic, but definitely means that if you have a patient that the symptom sounds true and legit for TIA, you should manage it urgently because the severity and recurrence rate is as high as a minor stroke. You require urgent treatment. Again, these patients, we have, for example, set up a few tele clinics in rural site, and also at the John Hunter Hospital, we have stroke clinics, but still it takes weeks to see us. Even we try to triage and do the things as fast as we can, but you are these ones, you are the key on this. The urgent treatment is on your hands. Untreated, there's a high short-term risk for subsequent events, which actually can be as high as 15 to 20% 90 days after a stroke. And the risk, I will show you in a couple of slides, happens over the first 10 days. And we don't see these patients. We do try, but we don't see most of them in that period. The treatment usually will be a combination of antithrombotic therapy, probably blood pressure management, and some of them statin use, assessment for AF, and definitely looking for symptomatic carotid stenosis. This combination may prevent a stroke in greater than 80% of the time. And the early antithrombotics, we will talk about that, is the majority of the benefit. That's the goal. Okay, is the patient having a TIA? Is something else? Look, the reality is that the brain is a complex thing and sometimes it's difficult. If the patient presents with more classic symptoms as a unilateral weakness, aphasia, hemianopia, or unilateral numbness affecting both face, arm, leg, this sounds like clear-cut symptoms. The problem is when it comes with those ones in the bottom of the slide, patients with just isolated dysarthria, that can be everything. Numbness in one limb, I think that can be also peripheral as well, or isolated dizziness. These are fairly complex patients. How are all the TIA the same, and how we stratified it? Look, all the symptoms are not equal, as we just talked about it. Dysarthria, ataxia, confusion, or vertigo has probably poor predictive value, while aphasia or hemiparesis has a much stronger predictive value. ABCD is good, it's not. Look, it helps to stratify. I think that is a great place to start. But it still doesn't tell you much about carotids. For example, in a patient with a high-grade carotid stenosis, even with a low ABCD, would be a higher risk of having another stroke. Still, on the flip side, probably the patient has a carotid stenosis because it has a lot of risk factors. You are all very familiar with it, and it's a good place to start indeed. Important to exclude a stroke sounds silly, but if sometimes the patient is still having ongoing symptoms and it's not a TIA, can be a minor visual field defect, a quadrantonopia. Many patients are not aware that they still have a visual field defect. And if we talk about the right hemisphere or non-dominant hemisphere symptoms as neglect, inattention, might be very, very, very subtle. Dysarthria or dysphagia sometimes can be quite subtle, and the patient even doesn't recollect that that's still happening. And many patients are not going to be strokes, thankfully, and they are going to be what we call stroke mimics. In the clinic that we run, well, actually around probably 50 to 60% of the patients are not strokes and finish with a different diagnosis. And that's completely fine. We need to screen the patients to be able to identify those that they have a stroke. Common mimics that we see anywhere in the clinic and internationally, seizures is a very common one, syncopes, functional disorders, migraines with aura, or sepsis actually 60% of the time. More likely a mimic, those patients, they have positive symptoms, so indicating an excess of neuronal activity. If they're visual as flashing lights, zigzag shapes, line shapes, objects, all that sounds more like a migraine-ish, probably. Spectrum, motor, jerking lip movements, probably can be a partial seizure. And always, for me, the most important bit I take in the history is the onset. Was it a clear acute or was progressive? Sometimes a stroke can present in a very unusual ways. Bilateral strokes, bilateral parietal strokes, they are very rare, but they present very unusually. The patients are very confusing, but not aphasic. Thalamic aphasia sometimes can be quite funny. It's different to a cortical aphasia, and we see it sometimes. Patients even with a cerebellar, they can have like funny symptoms, and probably, and some of them even they can have like an inversion of the visual fields. So what I mean and what I try to say is that sometimes symptoms can be very unusual, but if the patient explains a hyperacute onset, very sudden, definitely is important to think that might be a stroke. And always keep in mind, definitely, as mentioned, on the opposite side, the stroke and TIA would be negative symptoms, loss of functionality. When a patient comes with a stroke, I would appreciate if you could think about this slide. It's a busy one, but it's important, as this is exactly what is in the back of our mind every time that a patient comes with a stroke or a TIA in the clinic. 20% of them are going to be hemorrhagic, and I'm not touching anything on the hemorrhagic strokes, and I'm focusing this time on the ischemic strokes. 80% of them, and these are the 5 categories that the patient might finish being. 20% of them are going to be atherosclerotic, most of them related to carotid stenosis. We'll talk about it. Cardioembolic, 20%. Lacunar, small vessel disease, 25%. Infrequent, 5%. Cryptogenic, 30%. Meaning infrequent patients, they have a very rare cause triggering the stroke. For example, carotid dissections, we see that from time to time, especially in young patients. And cryptogenic means that we went through everything, as you know, and we were unable to find the cause of the stroke. And unfortunately, this still remains up to 30% in these patients. So the most important bit after a patient having a stroke, you need a brain imaging. Brain imaging, we agree, a non-contrast CT is a great place to start. Shall we do anything else? Yeah. We need to assess the vessels, and especially the extracranial ones, as atherosclerosis, especially greater than 50% stenosis, might be very relevant, especially commonly sitting in the carotids. I put you here a picture on the right. This is a cerebral angiography, and you can see a nasty plaque there on the left internal carotid artery. This can cause strokes because of a local thrombosis, because of distal emboli, distal hypoperfusion. Definitely all the patients that you suspect the patient is having a stroke or a TIA should have the extracranial vessel assessed. Carotid ultrasounds are a great place to start. Should you do, is it worthwhile to do a CT angiogram or an MR angiogram? Look, MR angiography are not great. They have a lot of noise and they overcall the stenosis, so that would be a no in my opinion. CT angiography is very useful and we tend to do it in the patients. But again, that's something that we can do at the time of the referral. But if the patient comes with already a carotid ultrasound, that's excellent. And that's what's actually in the pathway. Okay, we find a patient that has a carotid stenosis. Shall we treat or not? Definitely, the controversy is lessening, and those symptomatic vessels, meaning the patient is having a stroke or a TIA in the relevant territory, and stenosis greater than 70%, we should revascularize, we should treat. How we treat it? Both options, endarterectomy or stenting, are fair options. We tend to go towards endarterectomy, but in some young patients, we do stenting. Do we treat occlusions, complete occlusions, that they are chronic, that they have been there for weeks, months, years? No. Reality is that if a patient, the carotid is completely occluded, we do surveillance, but most of the times the contralateral hemisphere and posterior hemisphere and posterior vessels would be able to supply and give supply to that area and territory. But definitely we treat every degree of stenosis, 70 to 99%, we definitely treat it. Again, if it's symptomatic, if we just do a carotid ultrasound for any other reason and we see that the patient has a carotid stenosis and there is no stroke on CT, there is not a strong benefit. It seems to be, and I put it there, that there's an evidence growing, especially in those patients greater than 80%. But it's important. I'm not advocating here a screen for everyone. Vessels on the asymptomatic side detected during a stroke workup might be worth treating, but again, reality is that we shouldn't be screening every patient. This is an area that is still of greatness, and some patients might benefit, and these are patients that we are happy to assess and try to help to stratify in the clinic for sure. Okay, we need to treat. When? The sooner the better. The evidence shows that the 2 weeks after the event is the sweet spot for treatment. If we leave that untreated, the risk of another stroke increases. Okay, what else? The patient comes, we do the ultrasound, fantastic. What are we going to put the patient on antiplatelets? Of course we are. Shall we put the patient on aspirin? Shall we put the patient on clopidogrel? Should we go for a combination? Should we go for another antiplatelets? The reality is that there's 2 large randomized clinical trials. They're called CHANCE trial and they're called POINT trial, and both prove and compare the combination of aspirin plus clopidogrel versus aspirin in the recurrence rate of a stroke. So busy slide there, probably no need to go into details, but definitely there's strong evidence that those patients for 3 weeks is actually the point of major benefit for these patients to decrease the risk of ischemic events. And I think that this is the picture from the POINT trial from that we took part of it in Newcastle as well. And you can see the number of events and likelihood of events, the cumulative probability on the Y, and on the X, the days since the patient was randomized. And again, I would like firstly to show you how the majority of the events happen within the first 7 days. So again, this is a recurrence of another stroke within the first 7 days. So this is when the patient comes to your clinic. We even didn't receive the referral about these ones. We don't know if they exist. And this is the time where we need to act on them. And you can see how the combination actually already in 7 days, you're able to decrease around the 2% chances of having an event if you put the patient on a combination. And overall, this is a 90 days was this trial, it was a 1%, but actually what it was thought in a sub-analysis is that the 21 days here is the sweet spot and between preventing ischemic risks and not increasing the risk of having a hemorrhagic event. So the message is, if the patient doesn't have a cardioembolic stroke, no AF involved, aspirin plus clopidogrel is the way to go. A question from here that might come: if the patient is already if the patient has already a cardioembolic stroke and the patient has atrial fibrillation, should I add aspirin? Not really. You're just increasing the hemorrhagic risk, and we talk about that. Probably a switch to a NOAC would be, a different NOAC would be the best way to go. Again, going back to strokes, we need to be able to identify why the patient has a stroke. We need to take a look at the carotids. Another test to do is definitely doing a Holter, and 24 hours Holter coming to the clinic is extremely helpful, as again, 25% of the patients might have a cardioembolic stroke. So definitely in those patients with a stroke or TIA, worth to screen for AF, not in routine population, as we don't know what's the meaning of 5 seconds AF if they are detected by a device. But definitely in those patients that they had already an ischemic event, we need to screen for AF. How we do that? 24 hours Holter is great. It's a great place to start. For example, I have in the clinic, the second one, I'm not paid by them, believe me, but I found it's FDA approved. It's a great device. It's called the Caria IECG, and actually costs $200 and takes you 10 seconds to do an ECG, a single lead ECG, and our colleagues in the cardiology clinic, they use it as well. If they look abnormal, I confirm those results with a 12 lead, but it saves me doing a 12 lead ECG in each patient and makes it more efficient. The other option, if the patients of course have an Apple Watch, that definitely they are extremely well developed devices, and definitely that would help to identify atrial fibrillation. When the patient comes to the clinic, we use 2 different strategies. We can use a 30-day monitor, which is called Hardback, and it's a 2-lead ECG. This is an Australian company. Very straightforward. We just send it to the patients and they then send it back to the company. And in a selected small group of patients, we decide to put what's called a loop recorder implant in those patients that we have a high suspicion of atrial fibrillation, and we were unable to prove it with all the other methods. We just do it in a small number as the capacity that we have, and at the John Hunter to offer this to the patients is limited. It's a small number of patients, so we just try to go to those patients that after all these tests were unsuccessful on identifying atrial fibrillation. That would be our last resort. Okay, so patient with a stroke might have a stroke because of the carotids. Worth to take a look at the carotids. The heart, worth to definitely go and look for atrial fibrillation for long periods of record. Or the patient might have all the risk factors that we are very familiar with: hypertension, hypercholesterolemia, smokes 30 cigarettes per day, and presents with these small strokes that then we like to call the lacunar strokes. The picture on the right explains much better than what I'm going to do. These are strokes secondary to a blockage in one of the very small thin vessels that give supply to the deep part of the brain. And this is the same mechanism that, for example, I'll put you an example. 2 weeks ago, I had this patient in the clinic. He was 47. The patient was diabetic and already had complications, peripheral complications, kidney, eyes. So the patient already had all the classic complications of a poor control type 1 diabetes, and the patient presented with a small lacunar stroke. So again, this is the same mechanism affecting the small vessels in that patient. Again, how can I prevent another stroke would be about the prevention of the vascular risk factors, in that case, sugar control. And you will see, as this is around 25%, and this is the classic stroke, this or cardioembolic, that we will see in our older patient, 80 plus. And definitely the treatment will be antiplatelet therapy. Again, remember in these patients, the combination aspirin and clopidogrel for 3 weeks, and then we just stop one agent and keep on aspirin or clopidogrel. High dose of statins, atorvastatin or rosuvastatin are our preferable options from a stroke perspective. I wouldn't go for simvastatin, too many cramps, and risk factor control. And this is a picture of an MRI, and you can see here on the right basal ganglia did a small stroke. They are small, but they might be very disabling as well. So definitely worthwhile to prevent these ones. And many of these might cause and might lead to dementia long term. So definitely worth to keep control on this. Actually, in this patient here had already a chronic one. Okay, next thing and topic to talk. We could actually be in 4 hours talking about this. PFO. Shall we screen for PFO? Shall we close PFOs? What's happening? Obviously, PFO does not cause strokes. It's an incidental finding. 1 in 4 people has a PFO. But what happens though is that in those patients extremely young and very, very healthy with no other stroke risk for having a stroke, might have an emboli from the venous circulation that could bypass the lungs, that is a great filter, and cause a stroke if the patient has a patent foramen ovale. So the PFO screen is just indicated in the young patients. Actually, the clinical trials enroll up to 60 years with a possible embolic kind of cortical affecting the cortex of the brain, looking a stroke, and no other clear cause of a stroke. A clear trigger that we can see when we are getting the history if the patient was performing a Valsalva maneuver at the time of the stroke. If you want to confirm this, there are actually 3 different tests that might be requested. The ease here is doing a bubble study at the time of requesting the echo. But in the young patients, cardiology will do probably or ourselves a TOE before the PFO closure. And you can also do, and we do at the John Hunter, the right-left shunt using transcranial Doppler, and will tell us as well about the pass of the bubbles at the heart level, insonating the brain. We close patients with young patients with a stroke, but again, this is a minority. They tend to be, I remember a few months ago, a 17-year-old patient in the clinic, for example, had a DVT after a long flight. It was unnoticed. The DVT was asymptomatic, and we found a PFO, so we treated the DVT and we closed the PFO. And we will see a patients like this from time to time, but it's not the routine. And we don't close PFO for migraines. There's no evidence around that, if anyone will ask. Okay, different scenario is the very young stroke patient. Don't forget that patients sometimes might have a tear on the arteries produced by an injury or an impact that might be a carotid or a vertebral dissection, and this might lead to a stroke. I put you there 3 pictures as an example. The top right, chiropractic, sometimes after a session might be a wrong manipulation on one of the arteries and might lead to a stroke. And realistically, and being very honest, we've seen a considerable number of strokes per year after chiropractic. Surfing might be sometimes after hitting or falling after hitting badly by a wave, sometimes can cause a dissection. Rugby, I put footy there as well. So definitely sometimes patients might explain a clear trigger, and they can explain the stroke and follow a few days before by some sort of headache, retroorbital pain, or otherwise kind of irradiated neck pain. I'm not telling you that after every neck pain you need to image that, but definitely if the patient has an unusual pain coming from the neck towards the back of the eye that never happened before, that happens after a maneuver like that, worth to do an ultrasound. Ultrasound would be good enough to prove whether the patient has a carotid dissection, and that would be a very good reason for definitely give us a call. Atrial fibrillation, what happens if the patient has already atrial fibrillation? The patient needs to be anticoagulated. No need of putting the patients on antiplatelets, just increase the hemorrhagic risk. I put a few things about risks there, but I will probably just focus on the last line. The warfarin is just indicated for mechanical valves or severe mitral stenosis with atrial fibrillation. If a patient has atrial fibrillation, it needs to be on a NOAC. And which NOAC? Look, the 3 of them are very fair agents. We tend to go more towards dabigatran or apixaban, but we are very, very biased in the kind of patients that we see. We tend to see patients after large strokes and things like that. To the average patient, I think that the 3 are fair agents, and you might be able, guided by other particular details of the patient. How I do tend to manage. If I'm managing an old patient, fairly frail, with considerable overall hemorrhagic risk, I will tend to gravitate towards apixaban. If I have a young patient that my goal is definitely preventing another ischemic event, and I know that the patient is very unlikely to have a hemorrhagic event, never has hypertension, dabigatran would be my agent. And Xarelto probably more for those patients with extremely low kidney function. That would be my pool for Xarelto. Cryptogenic stroke and atrial fibrillation. Remember that 20 to 30% of the ischemic strokes are cryptogenic. We know that in those patients we can try to find more AF, and we can try to, some of them that are going to be AF related, and that's why we do the loop recorder. And also important to keep in mind the hardback, keeping those 30 days monitoring. That's something that we tend to do in the patients in the clinic. Almost finishing here. This is an interesting slide, as this was a huge debate for us over the last 6-7 years. What happens with these patients? I put you 4 pictures there. They're patients, they have these what we call embolic looking. They are cortical strokes. You can see the areas affected in each of these patients. There are 4 different patients. In the white area in the MRI. They are affecting different territories. This is an MCA and this is a PCA. Same in this one. This is MCA and PCA. This looks patchy and funny. Might be another tiny dot there. Okay, it seems like these patients, if they have normal vessels, we are always thinking about atrial fibrillation. So why we don't start to anticoagulate and we just cut all this workup? Actually, there were 2, that's not updated, I need to put 3. The 3rd one was published actually, I think last month, large multi-center randomized clinical trials comparing antiplatelet versus anticoagulation, the NOACs, in these patients with this kind of stroke-looking cortical strokes. They are navigate thesis, respect thesis, and the 3rd one is called Atticus. And actually it was negative for secondary prevention of ischemic events, meaning putting the patient on a NOAC just based on a gut feeling is not good enough. We need to prove atrial fibrillation, and actually has an increased hemorrhagic risk, obviously, in the patients on the NOAC group. NOACs are safe, but they are not aspirin. The conclusion, we need to capture atrial fibrillation, and sometimes it's a pain and takes a long time, but definitely we need to. Finishing. Okay, the patient has a stroke. I want to get some advice. I need to refer to the clinic. We have a stroke TIA clinic, rapid access clinic, and we have around 6 sessions per week at the John Hunter. And definitely, if you send a referral address to my colleague, Professor Spratt, he's the boss, my colleague Alvin or myself, we definitely will be able to triage that one. We have a telestroke clinic at Tari as well. It's important if the patient is from the Tari area, flag that the patient is from Manning area. So definitely we will be able to book there. And this is a teleclinic that I do with the stroke coordinator, with Emma McCartney there. And definitely this is a weekly clinic. And then we have a Mainland stroke clinic. I haven't updated this slide, and definitely this started in February 2022. So again, this is a fortnightly clinic. So if the patient is from the Mainland area, please flag to us. He's from Mainland. We take a look at the maps, I promise, and look at the addresses, but sometimes we get a few. So if you put that already in the referral, it would be extremely helpful for us and would avoid that we book in the John Hunter Clinic a patient from Mainland area. We are trying to do all this to provide a service to the patient that gets closer to them. So in reality, we have a few places there. And on top of that, don't forget that we have an in-house stroke fellow at the John Hunter able to answer every question. And we have always someone called for a stroke at the John Hunter Hospital. But especially important to highlight that in-house, our stroke fellow will be definitely very happy to guide you through all that, or after hours, the stroke consultant or advanced trainee. This is a summary. And the last slide, I promise, I've been talking for an hour. If you have a patient with a TIA or a stroke, first step, non-contrast CT. We need to exclude that the patient is having a hemorrhage. We need to determine the mechanism. Carotid stenosis might be, to an ultrasound, could be AF related. We need to try to move towards to a Holter, trying to get longer periods of recording, and that would trigger anticoagulation. In those patients with what we cryptogenic stroke, we have done Holters, the carotids looks fine, there's no other obvious cause, and has a cortical stroke, and they are young, might be a role of a PFO closure, and that's something that we tend to trigger from the clinic and refer to our cardiology colleagues from the clinic. And if the patient again is not in atrial fibrillation, the combination of clopidogrel and aspirin, we tend to load the patients with 300 milligrams of each to start with, and then followed by 75 milligrams of clopidogrel, aspirin 100 to 150. We tend reality to give 100 daily, and this for 3 weeks. After 3 weeks, important to move to a single antiplatelet. Which one? If the patient was already on aspirin, we tend to keep them single on clopidogrel. If the patient was aspirin naive, we will keep him on aspirin, and a combination with statins. Remember, atorvastatin 80 milligrams would be great. Otherwise, rosuvastatin 40 milligrams. I do like it quite a lot, as I do feel that the patients develop cramps less likely. And a referral to the clinic. I think that's all. If there's any questions now, or otherwise, if someone wants to send an email anytime, you have there my address. And yeah, questions? Thank you.
Thank you, Carlos. That was amazing. That was really good. I have a question from Jennifer Sharwood, and she's asking why stenting for younger patients and what's the benefit?
Good question, Jennifer. It has been a lot of clinical trials around endarterectomy versus stenting, and actually the large trials prove that those patients, young patients, they look more beneficial to the very young ones towards stenting. Why? Look, still, to be honest, it's a bit uncertain. Why? These are sub-analysis from the large trials. You can think, well, it kind of doesn't make much sense, isn't it? Because they would have less surgical risk. I thought that a few times as well. This is what the evidence is showing. The only patients that we see clearly indication, at least on my day-to-day practice, are to guide towards stenting versus endarterectomy is firstly anatomy. Where is about the bifurcation, and where is the how accessible can be for the surgeons that stenosis? That's first thing. And those patients, they had radiation on the neck. Those vessels become very difficult to treat. They are very frail, and they are not usually a isolated disease, but the vessel becomes very diseased overall. And those are patients that as well would benefit for having a stenting rather than endarterectomy, as you need to sometimes treat longer lesions rather than a short one.
Excellent. Is there any other questions anyone's got? There's no more on the chat.
Okay.
There's Sandy. Hi, Sandy.
Great.
Hi, everybody. Thank you, Carlos. That was fantastic. I really enjoyed listening to you speak. Thank you. And thank you, Sally, for being on the panel and looking out for questions for us. I guess it just remains for me to remind you that the recording of this will be available on the Education Library. And please do fill in your evaluation forms, and to thank you very much for joining us this evening. It's been fantastic.
Thank you, everyone.
All right.
Well, you have a good evening.
Great. Yeah, thank you very much.
Have a good evening, everybody, and hope to see you at another education event and another education event with Carlos. So thank you for that. All right.
Thank you.
Good evening. Bye, everybody.
Bye-bye.